Good morning. This is Kathy Waldman with the Society for Pain Practice Management, and good afternoon to those of you on the East Coast. First, I want to make sure that everybody can hear me. So if you can hear me, could you raise your hand? Okay, good. Thank you, Ann. Cindy, okay. Great. Thank you. We'll go ahead and start. So first, just some of the housekeeping items. Today's webinar is Beyond Telehealth, adding virtual patient monitoring to your practice. As many of you know, since the waiver and the relaxation of some of the regulations, we've been presenting webinars on telehealth to kind of educate you and help you stay on top of it. So today's webinar is just a continuing presentation to continue with some of the technologies that are available with telehealth and remote and even beyond. So this is remote monitoring. And I think, you know, a lot of you guys have embraced the technology to do telemedicine and telehealth with your patients, and I think that's a tribute to the flexibility of the pain management specialty and, you know, the medical community as a whole, that you've, you know, really rapidly embraced telehealth when the COVID-19 virus made it difficult for so many of your patients to see you in the office. And now many of you, the physicians and practitioners, have determined that there is a place for continued use of technology, you know, for your patient visits. And so that's why today we've chosen to bring you information on remote patient monitoring. There is a handout available in the GoToWebinar screen, and you can download that. It's a PDF. And there will be a question and answer time following the presentation. So just submit your questions through the question pane, and we will read those and answer those. And CME and CEU credit is available for this webinar. The Society for Pain Practice Management is accredited by the Accreditation Council for Continuing Medical Education, ACCME, to provide continuing medical education for physicians. So SPPM designates this activity for a maximum of 1.5 AMA PRA Category 1 credits. So you'll receive an email link to complete a quiz and survey and to attest to your attendance to receive the course credit. And please check our website and Facebook for upcoming webinars and courses. We also have a pain management blog that's sponsored by CE Medical, and there's post occasional things on there. If you've missed the past webinar, they are recorded, and the recordings are available for purchase. And make sure that we always have your updated email for our email list. We only use them for SPPM. We don't sell them, rent them, or give them away. The disclosure, Jake Levy is our presenter. He's the CEO of Health Tech Associates. He does have a marketing relationship with Claris Health, but we have determined that he is able to effectively present the information today. Catherine Waldman is a planner. I don't have any conflicts of interest. Patrick Inman is a planner. He has no conflicts of interest. Stephen D. Waldman, MD, the planner and medical director. He has no conflicts of interest. Matt Keith is a content reviewer and planner, and he has no conflicts of interest. And again, if you've missed a webinar, they are available for purchase through our website. SPPM has decided to hold our next comprehensive course as a virtual event. It will be recorded. Watch for those announcements and how to sign up and register for that. Okay, now what you've all been waiting for. Jake Levy is going to start our presentation on remote patient monitoring. He's a national leader in healthcare technology innovation. We're really fortunate to have him available to do this presentation today. He has over 25 years of expertise in home care with a focus on telehealth and remote care. He works with a wide variety of healthcare providers and their staff to use technologies to improve patient care. So he's a real entrepreneurial. He's got his finger on the pulse of telehealth and using technology to connect with your patients. So I think you'll really enjoy this webinar, and thank you for taking the time to attend. So now we'll go ahead and change to Jake.
Okay, so let's hand the baton.
There you go. I can see your PowerPoint. And I can hear you. Okay, perfect.
Great. Can you see my slideshow screen, Kathy?
Yes.
Okay.
And I can hear you.
Let me make one more technical adjustment on my side. And this webinar is starting just in time for the thunderstorms to roll through Atlanta and my dog to crawl under my desk. So that's one of the lovely things about working at home. Good morning and good afternoon, depending on where you are. I first want to thank Kathy and the Society for Pain Practice Management. Really, really excited about the turnout. Have really been looking forward to this meeting. I do want to start by just extending my gratitude for your practice and what you guys do. I have experienced it from a personal perspective, and just really admire the work that you do, and hope that by the end of our presentation today, I've been able to add value and create new ideas on how technology can enhance the practice. So let's get my slide to advance. Okay, all right, love that when that works. Yeah, I just want to add to my introduction just real quick. You know, I normally categorize myself as a health technology guy, but I think in the context of remote patient monitoring, I really do like to highlight, you know, much of my time as a health technology guy has been spent with home care and hospice providers. And, you know, I think being able to provide care at home is essential to what's happening in healthcare, especially in light of COVID and the pandemic. And I'm really excited that RPM has become such an important topic. It's not new to me. I've been evangelizing the possibilities of telehealth and remote patient monitoring for quite some time now. And, you know, maybe the silver lining in what's happening with this pandemic is it has help the providers, the clinicians, the practitioners really take advantage of the technology and kind of pushed everybody forward. So with that, I think I will cover the disclosure statement. So I, Jake Levy, have a marketing relationship with Claris Healthcare, a vendor in the remote patient monitoring market. I will use some screenshots to show examples of how the technology works. There are many reputable RPM vendors in the market, and I recommend looking at several products before making any purchase decisions. This webinar is based on the facts that I know them at the interception of this information being provided at this time. Information is subject to change as new information is released. Okay, so I think what I want to do is to kind of create some context. I'm going to go over kind of some healthcare challenges at a macro level, and I know that we all live these challenges each and every day, but I think it's important to kind of restate them, because ultimately what we're going to see is what a great fit remote patient monitoring is to addressing a lot of these challenges. So we all know about the silver tsunami. There's 56 million Americans over the age of 65. That number continues to grow dramatically, predicted to reach 80 million by the year 2050. I know that many of your practices are adjusting to or are impacted in some way by value-based care. There's a lot of statistics around value-based care and how that's impacting healthcare globally. Last year, nearly 2,600 hospitals or health systems paid out $563 million in readmission penalties. So I think there is, an important connection between being able to monitor patients at home and impacting some of these important value metrics. We'll talk about that shortly. I know that many of you practice in rural settings, I appreciate that very much. 10% of our nation's physicians work in rural healthcare, which represents 25% of our U.S. population. So there is a bit of disparaging between the ratio of physicians to population, and I think that the technology that we're going to talk about today is a way to cast a broader net and reach patients that have a difficult time communicating and seeing their practitioners. This is a really big challenge that I don't think is talked about enough, and it's the caregiver burden. I experienced this personally with my own mother, who is a pain patient and a chronic disease patient, and I'll kind of talk a little bit about Mom as we go through the presentation, because I think it's important to kind of put a little bit of a face around the challenges and the benefits of remote patient monitoring. But approximately 32 million Americans have provided unpaid care to adults over the age of 50, with an estimated $470 billion of economic impact. So we'll talk about how remote patient monitoring will help address that. And then lastly is just the overall cost of healthcare. So 71% of our entire $3.5 trillion healthcare budget is associated with chronic disease patients, and obviously pain is considered a chronic disease. If we dig in a little bit more deeply into some of the statistics, and again, I recognize you guys live these every day, but I think it's worth restating for setting some context. There are four key studies that I wanted to highlight. The American Academy of Pain Medicine reports the overall cost of pain amounts to $635 billion annually. Those factors include cost of care, medication, ED visits, hospitalization, missed work, and others. The Journal of Emergencies, Trauma and Shock reported an ED study that showed that 75% of ED patients cite pain as their chief complaint. The CD estimates that 20% of all Americans experience chronic pain. It's 50 million patients. There was a recent Veteran Affairs study that showed that 60% of chronic disease patients reported chronic pain. And we'll talk about as we move into the 5 steps of really building a program, how we want to focus on patients and who are good candidates for remote patient monitoring. And then the last one, which was actually surprising to me, is that pain patients visit their physicians 18 times a year compared to average patients. The number's actually 2.77 times a year. So I think it's really clear that technology can make a really big impact on this population. Okay, so let's talk about what remote patient monitoring is. Before I do that, I think it's important to kind of segue from a previous webinar that was delivered to the society on telehealth. So telehealth is defined as the use of digital information and communication technologies such as computers, mobile devices to access healthcare services remotely and manage your healthcare. Very broadly, today, telehealth is interpreted as virtual consultations. So Zoom calls, WebEx calls. I have an appointment on Friday with my GP, and I'm not able to go into his office because of circumstances. So we're going to do a telehealth visit, and I'm perfectly comfortable with that. We're going to broaden, or actually we're going to become more specific, and we're going to look at a subset of the telehealth industry, and that being remote patient monitoring. So as defined by CMS, remote patient monitoring is the use of technology to measure a patient's physiologic parameters at home. I think that's great. Remote patient monitoring is capturing vitals, but also it should include patient education to drive compliance. It should change behavior. It should include surveys to assess risk and effectiveness of your treatment programs. It should enhance and support enables self-care, safety, caregiver engagement, and overall health and wellness. In other words, I'm going to promote a very holistic view of remote patient monitoring in this presentation today. So, what does RPM have to offer? What are the key components that make up a successful RPM program? Well, the first one that I want to start with is access to real-time data so that your staff can make the best care decisions for your patients to be able to optimize their time. Secondly, to be able to capture vitals such as blood pressure, heart rate, weight, O2 saturations, blood glucose, temperature, and others. Even metrics like activity and sleep quality, even remote ECG, and digital stethoscopes to listen to heart and lung sounds. All of that is playing a factor in remote patient monitoring today. The next item we want to look at are surveys and medication reminders. I know that that has special significance in pain management practice. Patient education is important for compliance and self-care. Patient communication, including secure, and we'll talk about HIPAA security a little later, but including secure video, audio, chat, text, etc. Tying in the family caregivers or the informal caregivers, that's going to play a crucial role in supporting patient care. As I mentioned, this does affect me on a very personal level because I do provide care for my mother, who is in a very nice assisted living facility here in Atlanta, but they do not attend to all of her needs. So I do stay very much involved with her, and I do leverage her remote patient monitoring system for communication. In fact, I'll just expand. My mother's been in quarantine here in Atlanta since mid-March, but we can video conference every day through the caregiver portal on her. In fact, she actually has a little tablet in her room, and it's a nice way for us to stay in touch. And lastly, taking all of this into account, we want to be able to compile this information to create a decision support platform for alerts and notifications so that your staff has a clear picture of the patient population and where to best spend their time. So let me first outline the 5 steps to a successful RPM program. I really am trying to boil this down to a cookbook. So there's probably more steps that we can add, but I think for approaching this topic, these 5 steps are very appropriate. The first step we're going to look at is evaluating our patient population, who are good candidates and who might not be good candidates. Excuse me, I'm going to have some water while we're talking here. Thank you. Step 2 is determine your reimbursement model. I mean, that is one of the exciting things about RPM today, is CMS recognizes the value. They recognize the years of positive outcome studies, and that is why there is reimbursement. So I definitely want to break that down and how that impacts your practice. Third is to identify staffing requirements. A lot of people view RPM as an additional burden on the staff. Certainly it can be. I think it's really important in developing an RPM program to seek out programs and design programs that help optimize staff time, and we'll talk about ways to do that. The fourth item is selecting an RPM system. I'll share some thoughts on that, some key things to look for. And then the last thing is just to be able to manage our key performance indicators to see how are we doing. This is going to allow us to constantly make adjustments to our program so that it's sustainable and can grow with your practice. Great. So the first step is very important for us to determine where an RPM program can have the greatest value and impact. Who should be in the program? Where do we start? 85% of all Americans over the age of 65 have at least one chronic disease, pain being one of them. 56% of all Americans in that same age group have 2 or more chronic diseases. My mother would fit into that 56%. So I would suggest that we should first look at those higher risk patients and focus on where we can generate the greatest outcomes and have the greatest impact. Let's create momentum by serving those patients who need this the most. And as your program grows, you can work through different levels of acuity and different deployment models for remote patient monitoring to address larger populations. Other factors that are going to affect eligibility of the program are certainly going to be cognition. I think that remote patient monitoring in its essence is the collection of vitals. You have to ask yourself, is the patient able to take their measurement? Is there somebody available for the patient to take their measurement? Which is one of the reasons that I list caregiver support as an important criteria. Obviously, age is a factor. I've been surprised on my journey with remote patient monitoring just to see how well older seniors do on these programs. I have seen, patients that are 100 years old on remote patient monitoring. I do think age is an important factor, and I think we'll talk a little bit more about that when we look at selecting an RPM system. I think the goal is with any RPM program is to be able to address a wide range of patients, both younger adults as well as seniors. Willingness to participate it's obvious, but it's worth stating. I think when you roll out a remote patient monitoring program, it's a little bit of a sales and marketing approach to your patients. You want them to embrace it, to be exciting about it, and to drive utilization. Some factors for non-eligibility, obviously, access to the internet. People ask me all the time, what if my patient doesn't have cellular service, or what if they don't have access to the internet? Well, they're not a good candidate. I know that some of your practices deal with both inpatient and outpatient care. I just would say by default, remote patient monitoring is best utilized in outpatient settings. I have seen some use cases for inpatient, but what we'll focus on today is outpatient care. And then certainly the level of severity with your patient, the level of their severity and their condition may be a limiting factor as well. All right, step 2. Let's look at a high level for reimbursement. So as of 2019, CMS created the first 3 CPT codes. 99453 is a $21 setup code. 99454 is a $68 code for the collection of vitals. It's for the devices. 99457 is for the time of the clinical staff for in increments of 20 minutes. And in 2020, CMS came back with a revision and they added an additional code of 99458, which recognizes that many of these patients are complex cases and are going to require more than 20 minutes. Some may require 40 minutes of oversight. Some may require 60 minutes of oversight. So we were very happy to see the acknowledgement and the creation of 99458. So on average, total reimbursement for an RPM patient is potentially $165 a month. I do want to just notate that there is a 20% copay, and you would be responsible to try to collect the copay. If we looked at kind of comparisons to CCM, to chronic care management, on average, you'll collect about half of those copays. The exciting thing about remote patient monitoring is I think it really enables other programs such as CCM, transitional care management, behavioral health integration, and others. One of the things I like to point out is I know that a lot of you have adopted virtual visits and consultations through telehealth. I think that's great. You probably have some patients that just don't have a device that they can successfully conduct a telehealth visit with you. And many of the RPM systems will provide a device as part of that RPM kit, whether that be a smartphone or a tablet, a very simple tablet. It'll facilitate the virtual visit. Okay, so this next screen is a bit of an eye chart, and I'm not going to read everything to you, but I thought it would be helpful in your package to just have a chart of exactly what does the reg say for each one of the codes and then what are the important things that we really need to know. So let's look at 99453. So this is a one-time code, and it is for onboarding the patient. So this is the setup, the education of the patient. National average, factoring in locality, is $19.46. Code 9954 is for the equipment. Interestingly enough, this is billed on a 30-day period. It's kind of a challenge to track, and we'll talk a little bit more about that in selecting an RPM system. But from the time the patient is enrolled in the program, the 30-day period begins. One of the caveats with this code that I want to make you aware of is that you are required to collect vitals at least 16 days of readings per period. Also note that devices must be FDA listed, and the national average is $64.15. 99457 is reimbursement for clinical staff time. This was an important change versus the older code, which we'll talk about in a minute, that required the time be spent directly from the practitioner or qualified healthcare professionals. So 99457 expressly identified your NPs, your RNs, your MAs, and so forth, and their time counts in the monitoring process. 99457 is managed on a calendar month, so that's a bit easier. It does not require a face-to-face exam. The national payment rate for this is $51.54. And then lastly is the add-on code, which we talked about, and this is the additional 20 minutes. The important thing is, and we'll talk a little bit more about this when we look at different systems and different things to identify when you're selecting a system. It's important that the documentation not only identify the time, but what you did during that time. I do want to mention 99091. This is actually an RPM code that's been out there since 2002. It's been around quite some time. It is limited to physician and qualified healthcare professionals. It does require at least one face-to-face exam annually, and the national rate for this code is $58.38. This is for 30 minutes of time, as compared to 99457, which is for 20 minutes of time. So if you do the math, 99457 pays about 32% higher per minute, and I think that that's important. If we kind of extrapolate out what this means potentially for your practices, taking into account the average market cost for an RPM system, 50 patients on remote patient monitoring would generate around $100,000 in annualized revenues. 150 patients would generate $280,000 approximately in annualized revenues, and 300 patients on the program would generate about $570,000 annually. Obviously, that revenue number is gonna vary depending on your location and the underlying cost of your program and your staff. But the revenue potential is significant, and I think that the practitioners are well compensated for these programs. Let's move on to step 3. Step 3 is a look at staffing requirements. So if we're going to bill for 99457 and 458, we've got to make sure that we've got this covered properly. So what I'm encouraging you to do is examine your current nursing staff, your MA staff, to determine, do you have additional bandwidth? Or how can you repurpose some of your staff members to document the data that's coming back in, the interaction that you're having with your patients through remote patient monitoring. The benefit of managing these patients by your existing staff is that you're able to establish direct communication into the home of your patients, providing a very high quality of service, and potentially the ability to bolt on additional services. We talked about chronic care management, being able to add your virtual visits, perhaps behavioral health integration, and other billable services. One additional change I want to make you aware of: in 2020, CMS modified the regulation for 457 and 458 to allow for third-party monitoring. So there's a lot of good companies out there that have nurse monitoring for remote patient monitoring programs. This may be a good option for those of you that feel limited with staff. Obviously, there's a cost associated with that will impact the bottom line of your RPM program. The last thing I want to mention is, and this is important to set with your staff, is that remote patient monitoring is not a personal emergency response system. And it's important you set expectations with your staff as well as your patients, and make sure that everyone understands how the program works in the context of your normal business hours, what happens in nights and weekends and out of office. And so I think it's important to set expectations around that. But just to summarize that point, remote patient monitoring it's not a PERS system. It's not help by fallen. There are RPM systems out there that work in conjunction with PERS systems, but for the purposes of this webinar, we're just gonna leave it at that. Okay, step 4, and this is an exciting one and a very important one, and that is selecting the right RPM system. So there's a lot of moving parts. There's a lot of options out in the marketplace, a lot of really good options. I would say that these are 4 of the key components that I would be focused on if I were starting an RPM program in my practice today. I would look at level of engagement that the platform provides for patients. I would look at staff efficiency and how easy it is for staff members to engage on the platform, do their documentation and so forth. I would look at the ability to grow your practice. So we know that technology is changing very rapidly. We know that your care models evolve. We know that med management is going to evolve. So we need to make sure that these programs are very flexible, that you're not locked into, say, for example, only one type of a device. I've kind of seen that in the market. And then the last thing I'll mention is making sure the system is turnkey. I'll talk in more detail about turnkey in just a moment, but we really want to minimize the IT burden that this would have on your staff. So let's kind of break these down a little bit deeper. Let's talk about this idea of patient engagement. And this really goes back to my earlier comment when we were defining remote patient monitoring. I think patient engagement is one of those ways to unlock the full potential of remote patient monitoring, take that holistic approach. In order to be successful, we've got to drive patient utilization, right? Patients have to embrace the use of the system. And that's one of the questions that I would certainly ask your vendors is, what's the utilization of patients on your platform? If you're going to present them with a care plan that says, we want you to take these vitals, here's your med management routine, here's some surveys we want you to take, education and so forth, what is the utilization of that? So I think that's really important. We know how important education is for pain patients. There shouldn't be one way to engage a patient on RPM. I think that there are multiple levels of engagement. And this kind of goes back to the issue of age. There are some patients out there that would do great with an app on their smartphone connected to some vital devices, or taking surveys through the app, being able to do virtual visits through their own smartphone. I can tell you my mother's not a good candidate for that. She has a flip phone and it's rarely charged. So in her case, she really needed to be provided with a very simple tablet that's locked down and secure, that kind of helps her engage onto the platform. And then the last thing that I would promote here is the importance of tying in caregivers and family members. As much care and service that you provide your patients, you're never going to have enough time for what they really need to support their situation. And we know that involving caregivers, informal caregivers and family members is a really important ingredient to the overall health and well-being for your patients. Excuse me. Okay. So I thought it would be good to kind of present some examples of what does patient engagement look like in an RPM system. And so I just captured 4 screens here to show you. Screen 1 is basically the app waking up at whatever time is specified in the plan of care and reminding the patient, or coaching the patient through the capture of that vital. I know that if my mother's not reminded to take her vitals, she probably won't do it on a regular basis. And I want to remind you guys that you've got 16 days of vital recordings in order to be able to bill for that code. So it's real important that if you're going to roll out the program, that we're utilizing it as such. We know that surveying pain patients allows you to capture really important data that tells you how are they doing on their treatment. What adjustments do we need to make? I came across this really good screen that actually is asking questions specifically about pain, capturing that information and allowing your staff to analyze it. The third item here is just a very simple measurement of how severe the pain is. And the fourth item here is a very simple link to a website that takes the patient out to some information that's relevant for the kind of care that you want to provide. And so all of this should be very easy to set up and drive this patient engagement. Okay, ease of use for your staff. So there's about 5 things I want to talk about here. Staff utilization is as essential as patient utilization. We don't want an RPM program to overburden an already busy staff. So a well-designed RPM program should help optimize staff time by helping them focus on those patients that really require the utmost attention. So when we think about workflow and decision support, we're thinking about risk stratification. So if patients are doing okay on remote patient monitoring, that's great. What we really want to see is those patients where we need to actually, that our attention is necessary. Potentially there's an intervention required. The other thing that's really important on staff efficiency is the ability to convert your monitoring time to billable events. So it should not be a laborious task to be able to capture the documentation of time spent with patients and to be able to convert that over for a billable event for 99.4, 57, or 458. The platform should be highly mobile. We know that your staff, a lot of times they're on the go. They're not sitting in front of a computer dashboard. And we'll actually look at a dashboard here in just a second. But you can actually use these remote patient monitoring programs on your own smartphones. It's important to minimize the IT burden. You don't want to take on, break fix for devices. You don't want to take on inventory management for the equipment. You don't want to take on activating cellular services. Those are all things that we want our vendors to be able to manage. And then the last thing is the ability to integrate with your existing EMR. So your RPM system's capturing a lot of important information that ultimately needs to live in the patient chart, your main EMR. I don't want to minimize the effort that's involved with integrating to an EMR. We've probably, many of us have been through war stories of trying to tie things in with an EMR platform. But that is becoming an easier thing to do today, and there are protocols that allow different EMR platforms to ingest information and then share information back with remote patient monitoring. So I think that that's really important. Wanted to give you guys just a quick example of what I use the term dashboard. I think having a visual is really important here. As I said before, workflow, workflow, workflow. So we hear that a lot in managing an RPM program, your staff needs a tool to help them hone in on where they need to spend their time. This is an example of that traffic light approach, where you've got these care dots, red, yellow, green, helps me focus on different outliers potentially, alerts potentially. So these patients are going to be risk stratified up to the top of my workflow. And the last component is the ability to grow with your practice. And let's see here, excuse me. Right, so your software should work with 100 patients the same way it works with 10 patients. Your software should be able to scale to however large your patient base is without a dramatic impact to how you're operating. Being able to scale your RPM system is very important. So think about how your practice evolves. I know that you're oftentimes participating in webinars like this. You leave with information and you say, gosh, I really want to convey this to my patients. You need to be able to expand content within your RPM system so that you can share critical information as it becomes important to your practice. We've talked a little bit about the multiple deployment options. For a remote patient monitoring system, it's important that we have everything from connected devices that don't require any involvement to the patient. We use the term IoT, Internet of Things. There are a number of devices out there. You have patients that are going to be able to use their own smartphone, download an app, operate it from that perspective, and then kind of that fully kitted model where you provide the patient that smart device because they don't have one that's usable. And then the last thing that I'll mention that's really important is the ability to work with multiple devices or monitors. We use the term device agnostic. I can tell you the technology is changing very, very rapidly in terms of what's out there. You've got standard devices like blood pressure cuffs and pulse oximeters and things of that nature. And what we're seeing now is convergence of a lot of vitals actually working on a single device. There are patches out there. There are body straps that you can wear that collect information about heart rate and HRV and so forth. And again, just wanted to put a visual out there so you guys can kind of take a look at some of the more typical equipment out there. Let me just point out that's actually a spirometer that has become a really important device in light of COVID. I actually had a physician tell me earlier this week that even when we get beyond the immediacy of COVID, we're going to be left with many patients living with the effects of COVID. And he described that as that'll become the newest chronic disease. And this over here is a forehead thermometer. The last thing I want to mention in step 4 in selecting the system is this idea of a system being turnkey. We sometimes hear the term bundled solutions. So there are many important technical, security, logistical aspects to a successful RPM program. I've seen many vendors that handle some of these components quite well, but leave others to the customer or to your practice to figure out. I would look to vendors that can incorporate all of these into a single relationship wherever possible and minimize any unnecessary burden on your staff. So for time's sake, I will not list each one of those, but I think they speak for themselves. Okay, the last step that I wanted to mention here is really assessing the program. So how are we doing? What are our key performance indicators? And these are some of the things that I think we really want to be able to keep track of as we grow our programs. We want to look at the percentage of utilization. So one of the things that I've seen with a lot of RPM programs out there is they'll evaluate your plan of care and they'll compare that to the engagement for the patient. So how often are they taking their vitals? How responsive are they to your surveys and so forth? That is an important metric. We talked about value-based care earlier. I know many of your practices have a lot of drivers to reduce the readmissions, hospital readmissions, and that goes along with ED avoidance as well. Having those metrics at your fingertips are going to be really important to tell you how you're doing. I think another result in quality metrics is the way that your patients are responding to their surveys. Studies have shown that patients on remote patient monitoring programs that are successful are responding more favorably to their patient surveys. And that's obviously an important component of your value-based purchasing models. Being able to increase your merit-based incentive program scores, improvement activities, I believe, adds a 10% bonus to that. So it's important to be able to do that. And then obviously look at the level of reimbursement. So if you set out with an expectation of reimbursement, are you reaching that goal? If not, what sort of adjustments do we need to make? Is it an adjustment in staffing? Do we need to get some more training? Do we have a device that's not living up to our expectations? But being able to measure that is really important. I'm sure that there are other KPIs within pain management that are also going to be important to factor into this as well. I thought what I would do is just take a minute, let you observe a patient actually using a remote patient monitoring system. So let's see if I can get this to play. So you can see that the patient has a tablet in this case. I do want to highlight, excuse me, let me go back to that real quick. I did not mean to advance that. Let me just pause this real quick. Okay, that's not working very well, is it? Let's give this one more try. That's the last time I'm going to try to do this. I wanted to point out, these are Bluetooth connected devices. So while there is a tablet, there's nothing that's actually connected to that tablet. So as long as the patient is within about 30 feet of their device, whether it's their own smartphone or a tablet, the data is going to automatically be recorded here. In this case, you can see that there's an app that communicates back to the patient, and in real time, that information is going back over to your provider dashboard. Same thing as taking weight. Very easy to do that. You'll notice how thin these scales are. It's important to think about fall hazards. I've seen scales that are just too high for a lot of patients. So we look at little things like that. And then we'll look at this last measurement. So this is a pulse oximeter. We'll take this measurement. And what you'll see in this graph upcoming is you'll see a dip below the acceptable threshold of a pulse ox at 94. That would have triggered an alert in any remote patient monitoring system, which is what you would want. So it's really simple. I think that for the most part, this is something that your patients can easily adapt to. And in summary, I just want to say that success requires careful planning and solutions that are specifically designed for pain management patients. So think about how you can leverage these platforms to engage patients, improve compliance, change behavior, and oh yes, capture vitals along the way. So I appreciate everyone's time. I hope this was valuable and you've got some information that you can take back to your practices to enhance your care and explore alternative models. I'll be happy to take any questions.
Okay, and you know, Jake, as I've been listening to this, as many of you know, I've been involved in pain management for quite some time, and I'm sure a lot of you, your mind was just worrying of all the things that ways that this can be added to pain management. You can monitor after you do epidural blocks or other procedures, spinal cord stimulation, implantation procedures. You can monitor the patient afterwards, check their temperature. There's just a lot of uses, I think, in pain management, medication management. And like Jake, I'm also a caregiver, as I'm sure many of you are. And I can see a lot of uses for remote patient monitoring. It's pretty exciting. So the first question is from Anne. Is documented patient permission required for code 99457?
Absolutely. So you do have to have patient consent. Most of the RPM programs have a suggested consent form, or they'll work with your practice to incorporate that into their platform. So when the platform arrives, the first thing that is ticked off by the patient is this consent. So yes, it is. Any other questions?
We'll give you guys a minute. If you want to type them in, there's a question pane, and you can just type in your question. And you also have Jake's contact information. So if you do think of a question later, you can email. Oh, here's another one. Who buys the equipment?
That is a great question. Typically, the practice is bearing the full cost of the RPM program. I have seen, a few different models. I have seen models where the practices are buying the equipment, they're purchasing the equipment themselves, and that is definitely an upfront expenditure. I've also seen models where everything is provided as a service. So the cost of the equipment, the software, in many cases, the 4G data plans that might be required on some of the smartphone or tablet devices, all of that is bundled in. I happen to have more experience with the latter, the SaaS models, software as a service. Sometimes we use the term RPM as a service, and that may be helpful for some of the practices that really don't want the upfront capital burden on the equipment. Good question.
And then Jennifer asked, how do we get set up to do this?
How do we get set up to do this? So could you be a little bit more specific, Jennifer? I'm not exactly sure how to answer that question. Let's take the next question and we'll come back to that one, hopefully.
Okay. Okay, and Lynn asked, please comment more on the internet requirements.
Sure. You got to have access to the internet. No, I don't mean to be facetious. So the RPM systems that I have the most experience with handle that connectivity for you. So for example, I've mentioned my mother a few times. Mom has a 4G tablet with Verizon service on it. I didn't have to activate anything. I didn't have to, there was no, there was really no involvement. In fact, her tablet will also work on Wi-Fi. What we found out is that the Wi-Fi service at her assisted living facility is horrible, and it did not support the video visits. Once we turned on the 4G, which was just a switch in the app, everything became clear and fast, and it was very effective. So, there's a lot of different ways that you can take a device and make it internet accessible. Many of the vendors will support multiple wireless carriers. Many of the vendors will have, devices that will work on Wi-Fi. But ultimately, it really is important to kind of vet this out with your patients. I was involved in an implementation very recently in a rural area in Tennessee, and they were very clear to tell me that there was a specific carrier that did not work well in their area. And I won't mention who that carrier is because that wouldn't be fair. Okay. Kathy, any other questions?
And Andrea, in order to Yes, in order to bill for 99454, the patient would need to take their own vitals every other day, all vitals.
Yeah, that's a great question. So the way the reg is written is the patient has to take a vital within 16 days of that 30-day period. So let me go back again and say that this is a little different than 99457, right? Leave it up to CMS to make this more complicated than it needs to be. The monitoring time works on a calendar basis. For whatever reason, the 99454 works on a 30-day rolling calendar. So you make a note of that, because when you're looking at systems, you got to make sure that their billing reports are adjusting for the different bill cycles. So on 99454, as long as you have 16 readings within that 30-day cycle, you can bill for it. And let me see if I can go back a screen here, Kathy. Hang on one second. I just want to show you an example of where that's important. On this dashboard, we kind of talked about information that your staff is going to be taking a look at. Well, one of the thresholds here, or actually both of these, are going to show up on this dashboard. So, you know, I'm still short of 16 readings within a 30-day period, and the system's going to alert me to that. So if I were at, you know, day 29, and I saw that I had a patient on my dashboard that had, you know, a red dot and it had 15 readings, I'd probably reach out to that patient and have them take their reading. The second part of your question was, if you've deployed, let's say you deploy 3 devices to a patient, a scale, a blood pressure cuff, and a weight scale. According to the reg, you only need one of those vitals to qualify for billing. Great question.
So, Jake, you mean 16 total readings?
16 days of readings. Yeah.
Okay.
Yeah. So, for example, if they take 3 readings on one day, you get credit for one of those 16 days.
But they don't have to do all 3 devices on that day to get credit. They could just do their blood pressure on Monday and weigh themselves on Tuesday, and you would get credit for 2 days.
That is correct.
Okay. So Jennifer followed up. She said, so we just need to contact a vendor to get more information on getting this set up for us.
Yes. And I did provide my contact information. I obviously work very closely in the vendor community and would be more than happy to kind of walk you through a plan. I mean, it's remarkable how easy it is to get set up on remote patient monitoring. This is not, you know, deploying a new EMR system.
And Chris asks, are commercial payer reimbursements similar to Medicare?
Yeah, it's a great question. Right now, to be honest, it's kind of hit or miss. You know, the Medicare Advantage programs have certainly embraced it. A number of the state Medicaid programs, I'm working on a project in North Carolina, and the state of North Carolina has adopted the same codes for Medicaid as they did for Medicare, and the commercial payers tend to follow CMS on coding. So, you know, the pendulum has definitely swung in a positive direction for that. I would check with your specific payer on that. Good question.
Okay, and Lynn asked about the handouts. Again, the handouts, if you look kind of to the right and towards the bottom of your GoToWebinar pane, the handouts are in there to download. If you have trouble downloading, Lynn, I can email them to you, and we will send a link for you to rewatch this webinar again. I know this was a lot of information, and a lot of it is new to us. Let's see, Vicki asked, does Medicaid cover these services, VPT or only Medicare? We are a heavy Medicaid HMO population.
Mm-hmm. And that was from Vicki?
From Vicki.
Yeah, Vicki, can you share what state you're in? I'd like to know that before I respond.
And you can just type it there in the handout pane.
The only reason I asked specifically your state, it does vary from state to state. And it's amazing. I mean, COVID has pushed a lot of this technology across the finish line for us, for practitioners, you know, as well as consultants that have been pushing this for a long, long time. So I am involved in several RPM programs in different states where, you know, where Medicaid is reimbursing.
And Vicki said she's in California.
Vicki, could you email me that question and I'll get back to you with some specific information? Thank you.
And then Jennifer says, we see a lot of Medicaid here in Missouri. Would these codes be covered?
Yeah, Missouri is very favorable to both telehealth and remote patient monitoring. In fact, I have a very close partner that's in Kansas City that if you want to email me directly, we can provide some information on that as well. Interestingly enough, Missouri adopted reimbursement for remote patient monitoring years ago under their Medicaid program, and it was definitely use case driven, but that was in a home health setting. So it seems to be embracing the technology.
And Andres asked for 99457. Any type of provider qualifies or only MDs?
Yeah, that was a big change with this code. So, you know, the term is any clinical staff or third-party monitoring. So it could be MAs, you know, your nurses, your NPs. It does not require a physician to sign off on that before billing. So, you know, I think CMS really did a nice job in designing these codes to work very well within the practices. I have physicians that ask me all the time, you know, how much of my time is this going to take? And, you know, the answer is this, if you've got a good triage staff, you can repurpose, you know, to taking a few minutes a day to just peruse the dashboard, look at what's going on, click into a record. You know, the cool thing about a lot of these products is they automatically are tracking time. So if I just give focus to, say, this record for Sarah Haskins, some of you may recognize that picture, but if I just give focus and I click into that record, behind the scenes, there's a timer that's tracking that information for documentation purposes.
And then Ann asks, I'm in Wisconsin. What would you say is the biggest difference between CCM, telehealth, and RPM, besides the equipment, of course?
Wow, what a great question. So so what's the difference between the two? I think that there's a lot of crossover between, you know, CCM and RPM. Let me differentiate telehealth first. I think telehealth is a much broader used term. We really interpret telehealth to mean virtual visits. I mean, that's typically the primary use case when we talk about telehealth. The difference between remote patient monitoring and CCM, there are some regulatory differences in terms of how it's billed, but really the difference is the monitoring of vitals, the physiological data. I think that probably is the largest difference. And I do have some supplemental documentation in my possession that I'd be happy to share on breaking down the actual differences in these programs. I've got a nice chart that probably would have been helpful to share in this webinar, but if you want to reach out to me directly, I'm happy to send that to you. It's a good question.
And if you want to send that to me, I can post it on the blog portion of our website as well for everybody to see. And then Andres asked for 99458, the reimbursement for an additional 20 minutes or a fraction thereof. Oh, is it for 20 minutes or a fraction thereof above the first 20 minutes.
Yeah. No, it's not a fraction. It is 20-minute increments. So if you bill 20 minutes for the first, 99,457, and you're 18 minutes, so you're, 38 minutes of total care, I suggest you reach out and spend a few minutes with that patient, see how they're doing, check in on them.
So if it's 19 minutes, you're not going to get paid for the 20 minutes. That's bottom line.
Kind of what I'm saying, yeah, which is really important.
So monitor your time and make sure you really do spend the time.
Yeah, and your system should help you do that. So, you can see, this billable time here. I'm at 26 minutes. The reason it's yellow is I got 4 days, to make up another 14 minutes of time, or I'm not able to bill for that.
So what you're saying is that 20 minutes doesn't have to be in one visit. It can be over a week or 30 days.
Yeah, so you're collecting fractions of time. But aggregate, you've got to be able to show 20 minutes of time. It's not a single block of 20 minutes. It's a very good question, Kathy. Thanks for clarifying that.
And then Lynn asked, is the clinician liable for abnormal vitals? How do you suggest we handle that?
Is the clinician liable for abnormal vitals? I think your question is the clinician liable for not responding when there's an abnormal vital? Can you just clarify what you mean by that?
She said yes.
Yeah, so let me refer you back to your healthcare practice attorney. I think what you'll find out is that you have the same liability that you would have, when you're engaged with your patient, to provide quality of care. So I don't think that you're responsible for equipment malfunction, but I would definitely talk to your, to your provider about what those risks. I'm sorry, to your attorney about what those risks are. I'm hesitant to give any further comment on that.
Okay, and then Andre says, using Norman Zindel as an example, he has one reading in 28 days. It would be impossible to comply with the RPM reading requirements in this case, correct?
That is correct. Yes, and just caveat, all of this is fictitious data that's on this screen. So don't read a whole lot into the numbers, but you're absolutely right. Someone has really not been paying attention for Mr. Zindel.
And Rita asks, do you know if Oklahoma Medicaid will pay?
I don't off the top of my head. If you'll email me that question, I'll get some information back out to you.
Okay, are there any more questions? And then Andre said Florida. So, and Rita and Lynn and Jennifer all said thank you.
Yeah, this is great. You guys asked some terrific questions, and it was a real honor to present to this group in particular because of what you do. I really appreciate the opportunity, and I'd be happy to work with you on an individual basis if there's anything that I can help with in standing up an RPM program for your practice. I want to thank the Society for giving me the opportunity, Kathy. It's been a pleasure to work with you.
And I appreciate you taking your time today. I know you're busy, and I think this is great information for our group. What they'd really like you to figure out, Jake, is how you can do urine drug screens remotely.
I get asked.
You'd be your favorite vendor.
I don't think we're far from that, actually.
Yet.
Yeah, I really don't think we're that far from that. So, yeah, let's keep our eye out on that one.
I think there are a lot of applications. I appreciate all of you that have really embraced the telehealth and trying to connect with your patient remotely and staying in touch with them at this time. I think there's a lot of people who aren't getting the health care they need, and I appreciate you guys really taking the time. I know it's, in talking to some of you, it's been a bit of a challenge, but just hang in there. I think people are getting better. I think a lot of the older people are actually really embracing it and trying to do the best they can. I've seen it, like Jake, with my own parents. My mom wants nothing to do with it. She wants her doctor that retired 20 years ago to come back. My dad, on the other hand, he does it all. He has an Apple Watch and an iPad, and he does virtual visits and takes his blood pressure and all that. And so it can be done. Caregiver support is important, as I'm sure all of you know. But don't discount somebody just because they're in their 80s.
Yeah, I was going to add to that, Kathy. So my mother turned 83 last month, and she has struggled with severe back pain. And when we put her on an RPM program to help her manage her weight, surprisingly, surprise, surprise, her back pain got better. Mom's actually lost 40 pounds. She did have a weight problem. She can probably stand to lose some more. She's lost 40 pounds. She'll call me and go, "Did you see my weight today?" Now, I can tell you, Mom's weight is not something she wanted to discuss with me for quite some time. What I am seeing, not just with my mother, but across the board, is that we are changing behavior with the technology. And it's just so gratifying, as one of these guys that's been running around the country and running up and down the halls of the HIMSS conference, evangelizing this stuff. It's really, really great to see the practitioners embracing it. As I said in the beginning, COVID's probably pushed a lot of us into that pool. I don't think we're getting out. I think this is the new normal as far as leveraging the technology. And at 83 years old, my mom does great with it and enjoys it and loves the fact that she gets to see her grandkids whenever she wants on their app, on their phone. That may be a little too much for her grandkids sometimes, but there's a lot of engagement there for her, and it's really modified her behavior in a very positive way.
That's great. That's great. I think it's important in general, but especially now. And then Dr. Cintron asked, please comment on urine drug screening in the future talk for our paying patients on opioids. Those patients are hesitant for in-person visits with COVID.
Yeah, I'm going to go off and do some research on that. I don't have anything to comment today, but it's a great question. And if you'd reach out to me directly, that'll be something that I'll be happy to do some digging.
Okay, thank you. I think that's the last of the questions.
Thank you so much.
So this concludes the webinar for today. Please complete the handout had a link to the survey and the quiz, and you can attest to your attendance to receive CME and CEU credit. So please complete that. We will email you a link to this recorded webinar. And again, if you have any questions, contact Jake, and either he or Luann Gonzalez will respond to your questions. And thank you very much. Hope to see you guys again soon.
Thank you. My pleasure.
Okay, thanks.